Well, let us begin. Welcome to everybody. I'm Bobby Dubois. I'm the interim CEO and the longstanding Chief Science Officer at the National Pharmaceutical Council. Many of you on this call I know, and welcome. Those of you who I don't know, welcome as well. So we have a really important and timely topic, which is really thinking carefully about budget caps. As folks know, other countries cap how much they want to spend on healthcare and how that might grow year over year. Our friends to the north in Canada, that is a big part of what they do at the provincial level, and it's a very important part of their public dialogue. So the question is it a good idea or not? And can it meet kind of the dual goal of constraining spending on health, but also preserving health? And that is a really tough trade-off. Done correctly, perhaps it can work. Done poorly, it can definitely create problems. And so what we hope to talk about today is what exactly is happening in the budget cap realm around the United States, what aspects of it are problematic, what aspects are not problematic, and how might we think about this moving forward in as productive a way as possible. I don't need to repeat this. You guys read it in the newspaper practically every day. Healthcare costs are rising. Now, there are lots of ways that folks have tried to address this issue. One I might call the piecemeal approach. Oh, there's so much administrative waste. Let's do something about it. Oh, there's so much low value care. Let's get rid of it. And those will constrain spending. Okay. That's what I would call kind of the one of the kind piecemeal approach. Another approach is a more holistic one. And that's where budget caps fit in, which is if you constrain how much you spend, then you're going to presumably drive change in utilization, in prices, and any other kind of thing. Now, the challenge, of course, is if you constrain a budget, yes, you can reduce spending. No question about it. Other countries have shown that. Now, the problem is, what does it do to patients? What does it do to patient health? What does it do to subsequent innovation so that we can continue to do better and better and better? And that really is the focus for today. Now, in the next slide, this is not just a theoretical exercise. Now, we have 50 states, and you can see most of those are the gray color. The gray color means nothing happening in those states on budget caps. But you can see there's a certain number of states that have yellow, and the yellow connotes to they do have some sort of budget cap model. Now, in Delaware, it doesn't really have any binding power to it. It's just monitoring. Massachusetts, they also have a policy, also not formally binding, but it is publicly discussed. And some folks feel it's been successful. There are a bunch of states thinking about doing that or doing one of these kinds of things, and that's the ones in blue. And there is one state, which is New York State, which has a budget cap at a silo level, not overall spending, but in their case, at the drug spending level. So these are things that are beginning to be talked about, starting to gain some traction. And in the policy sphere, if folks are going to make choices, we want to make sure they're as informed as possible. Now, the next slide is that, we certainly wouldn't want to confuse this with evidence now, would we? But yes, in fact, we do want to bring evidence to this dialogue. And so later in the hour, we'll hear about a research study that examined various ways of doing budget caps, some of which seem to cause more problems and some fewer problems. And so we'll learn from that sort of best practices to consider. Okay, so we have in the next slide, we have wonderful panelists that are going to teach us all about it. and I will walk through who those are. Now, these are very brief descriptions of the folks. If you want to see full speaker bios, just go to the NPC website, which is npcnow.org. So Matt Salo has served as the executive director of the National Association of Medical Directors for 10 years. And his association represents all of the states and territorial Medicaid directors. And that organization provides a strong unified voice in national discussions, as well as a locus for technical assistance and best practices. He has a real finger on the pulse of what each and every state is doing from the Medicaid standpoint. Andrew Sperling has been the Director of Legislative and Policy Advocacy at the National Alliance on Medical Illness since 1996. And he oversees NAMI's federal policy agenda in Congress and before federal agencies. He serves as a consumer representative to the National Association of Insurance Commissioners and as the co-chair also of the Consortium for Citizens and Disabilities Housing Task Force. So Andrew will bring the voice of the patient to the discussion. Yes, we might save money, but at what potential impact on the patient? We'll also have Hamie Tourison, who is currently the visiting senior policy fellow at the Duke Margolis Center for Health Policy, but very soon, very, very soon, June 1st, will leave that organization and will then join the National Academy for State Health Policy as its director, leader, and visionary. Previous to where she is currently, she was the director of the health division at the National Governors Association Center for Best Practices. She absolutely has her finger on the pulse about state issues more broadly, and she and Matt, between the two of them, can handle what the perspective is from that standpoint. And then finally, from our organization, Mike Cimitero, who serves as NPC's Vice President of Research. Mike plays a major role in developing and delivering NPC's portfolio of health policy and health outcomes projects. And he will review the study that I alluded to later and will bring some evidence to this conversation. So the next slide are the questions we hope we can wrestle with over the next 45 minutes or so. First, what's the landscape of budget cap use? Second, what can we learn from those programs, from Medicaid, from others who have experienced fixed budgets? Third, where do budget caps present potential risks for patient health? And importantly, what can be done to mitigate those risks? And the good news is there's some very tangible steps that can be taken that would make things more likely to be beneficial for all. And then lastly, how can patient needs be better reflected, included, considered in budget cap programs? So with that, I would like to turn it over to Hamie to give us the state perspective, or the first of our two state perspectives.
Thank you, Bobby, and just really appreciate you having me here today and being able to speak to all of you all, albeit virtually. So I thought I could just start talking a little bit about the state perspective more broadly, and I will let Matt really talk in more detail about Medicaid. So, I think as we all know, states, unlike the federal government, do have, they have to balance their budgets. And they have to make hard choices when they balance their budgets. They don't have the option to decide, well, this year we're going to just have a deficit and we're going to let that slide and make it up in the next, 5, 10 years like we do at the federal government. And because of that, there are different pressures that governors and their teams really have to work with their legislature to address. And so, I really just thought I needed to set that context for we're talking about healthcare spending. The Medicaid budget alone is, sometimes up to 25 or 30% of total expenditures for a state, state and federal, share combined. So when you see growth in programs, whether it's Medicaid or state employees or other parts of your state budget, you really do have to decide, how do we make sure for the longer term, we're going to do what's right for our state? And so, states for many years have been thinking about how do we drive more value in healthcare? We all know, healthcare on average is growing at a rate more rapidly than, other sectors. And that's for a number of different reasons. And so, states, just to take a step, back from just budget caps, states have been thinking about a lot of different ways to drive more value into the system by, lowering costs and improving outcomes. And I think we've seen in the past, there's models like, accountable care models and episode-based payments and, rural health model in Pennsylvania, total cost of care in Maryland, commercial market affordability, where, governors and their state officials that work for them really have thought about how do we make sure, number one, we're ensuring that costs are affordable for the people in our state, and number two, that we're going to have the money in our state budgets over the long run to do the right things, not just for healthcare, but for the other sectors that are so important, like education and infrastructure and all the other things that states budgets have to cover. So just to turn to, so Bobby did a really nice setup for what's happening on the budget cap conversation. And really, prior to COVID, there was a lot of interest in how do we think about pharmaceutical costs and concern about, new drugs coming to market. While they're bringing like really great innovation, they have pretty high price tags. And how is the state going to be able to afford that along with everything else that they need to cover under a program like Medicaid? And so there was a lot of interest in, how do we think about, controlling that growth and making it more sustainable so that we're going to be able to spend the money like we need to in, years to come. I would say, in addition to that, there's also sort of concern across the board for healthcare costs. With sort of that same point in mind, Bobby talked about Massachusetts. Massachusetts was really the first state to set up a cost growth benchmark, and that's because they were first in the country for their healthcare costs, and they were out in front by a lot. And so, really, and a lot of it was the prices of their healthcare system, and there really wasn't, there was a monopoly on the market of the different, health systems, and so there wasn't really an ability to control costs. So there was a decision made, whether you agree with it or not, one thing that we're going to try is really try these cost growth benchmarks, which is really a cap or target for spending growth. And in Massachusetts' case, across payers. And so, they, unlike some of the other states that have come behind them, they have a really big infrastructure where they've done a lot of analytic research around, how to set the targets and, what are the different data analyses. And so if that interests you at all, they have a wealth of information, I think, on how that's gone in Massachusetts. The other state I want to talk a little bit about is Oregon. So Oregon also has a longer history with cost growth benchmarks. And they really started that in their Medicaid program, where they set a target years ago. I believe it was 2009 when they first started proposing this, of setting a target for their Medicaid program because of this really incredibly difficult budget shortfall they were facing. And so, along with the setting the target, they also got approval from CMS for a big waiver where they set up their coordinated care organizations and really tried to think about how do we change our system of care. So that's another state I would suggest, if you're interested in this, looking at, how is that gone by setting a cost growth benchmark in Medicaid, since they have many years of experience. Now, since that time, there have been a number of states, and Bobby listed them, really interested in this model because they're looking for ways to actually think about how to control the growth of their healthcare spend. And, Delaware and Rhode Island were two states. Now, they're smaller states that came after Massachusetts that really decided, we're going to try this. Now, Rhode Island's interesting because Rhode Island had already built up a pretty interesting commercial market affordability set of standards. So they were, emphasizing investment in primary care, along with making sure that they had some control over the growth in their commercial market. And that was then the cost growth benchmark was in addition to the things that they already had in place for many years on those two fronts. In addition to those states, Oregon has now decided, they've had all this experience in Medicaid, they're going to move to the commercial market with their cost growth benchmarks. And both these benchmarks can also have quality benchmarks. It's not just about the cost, but it's also about thinking about clinical quality, under or overutilization, and patient safety measures. So I say that because it's not just a blunt instrument on like you shall not spend over a certain amount. It's also thinking about how do we also improve the quality of care and make that a benchmark as part of these targets. So Oregon is now going to move to commercial market with the cost benchmarks by 2021. They're also going to set targets for primary care spend to go up to 10% by 2025, and they're going to implement the quality benchmarks by 2022. Another state that's coming on board is Connecticut. Connecticut also has a similar trajectory as Oregon, and they're going to set both the cost benchmark across payers as well as the quality benchmark around the same timeline. There are two other states that are on Bobby's chart that I just wanted to mention, New Jersey and Pennsylvania. They have issued directives that they're going to establish cost growth benchmarks, but they're really early in their journey on this. So, I believe in New Jersey, the governor just issued his executive order, in January, I believe, and in Pennsylvania, it was earlier this fall. So that's in the midst of COVID pandemic response, and they're now working on, how do we launch this initiative and what will that look like? So I will say, I think in addition to the states I mentioned, there are a couple other states that are interested in this model, and I definitely think it's something to continue to follow because there'll be more momentum. And I guess the last thing I'll just leave you with is, in addition to sort of this cost growth benchmark piece, I do think there's some real interest in multi-payer alignment. I mean, I think we all are interested in driving more value in our healthcare system. And so in areas like primary care and behavioral health and addressing equity, I think there's a lot of opportunity to work across payers to figure out how do we make those improvements while addressing the cost of healthcare. And, with the American Rescue Plan and $1.9 trillion available largely for states and other entities, this is an opportunity to think about how to make investments while we also think about how do we improve our healthcare system while we don't continue to spend in a manner that's not going to be sustainable. So with that, I think I'll turn it back over to you, Bobby. Thanks.
That's a wonderful beginning to our dialogue. And let's turn to Matt to continue the state discussion now from the Medicaid standpoint.
All right. Thank you, Bobby. And thank you for that kind of lead off, Hammy. You are going to be a terrific executive director over at NASHB, and we look forward to working closely with you there. So I wanted to kind of frame out a couple of things first before diving into a conversation here. So I think, it's always important to set some baselines around just what Medicaid is and who are Medicaid directors and what do they do and why is that important. Hammy referenced the fact that it is a big program. It could be 25-30% of the state budget. Pre-pandemic, it was spending $600 billion a year, and by itself, it's 3% of the nation's GDP. But we're also covering 1 in 5 Americans, and Medicaid is, kind of simultaneously the nation's largest provider and payer for behavioral health services, the largest provider and payer of all sorts of things, ranging from HIV/AIDS treatments to the fact that we cover about 40% of all kids in the country, close to 50% of all the births in this country, and it is by default essentially the nation's long-term care system. And it has to do that basically driven by the engine of state government and state general revenue, which is not always an easy platform to continue to drive such an incredibly important program. And what do the Medicaid directors do? Rather than just kind of sure, they run a program, but I kind of describe it as their task is to take the largest, most complex healthcare system in the country, if not the world, and try to drive better patient outcomes, improved health and wellness, and functioning in the community for a large number of individuals who depend on it, while doing so within very, very constrained budgetary challenges. And as Hammy said, not only do states have to balance their budget every single year or on a biennium, but one of the ways that Medicaid works is because it is a joint project between the states and the federal government. And practically every state operates some part or the entirety of its Medicaid program through a big waiver with HHS. a key component of essentially all of those waiver programs is a sense of budget neutrality, a sense that, over a window, a 3-year window, a 5-year window, some other window, the program will spend no more over that window than projected at the beginning. And so this whole concept of we have to live within our means, we have to balance budgets, we have to be mindful of what do things cost, is just, it's so baked in, it's so endemic to the experience of the Medicaid program, that, when Bobby first reached out and said, hey, we want to talk about budget caps and why they're a challenge, I was like scratching my head saying, but that's just like you're questioning the core nature of reality. Like I don't get it. And I think I would still kind of push back on just the basic framing of the question, which, in that first slide was, budget caps, yeah, but can they harm innovation, and can they lead to, adverse impacts on patient health? And I think I really challenge that. Medicaid has been doing this for decades. And I don't find a whole lot of real world, reality in the sense of that's impacting innovation. It just isn't. And again, like I said, the core experience of the Medicaid director of the Medicaid programs has been, yes, we have to operate a program within budgetary constraints, but it is all about the beneficiary. It is all about how are we impacting their lives? How are we making their lives better? And I think there's a real challenge. The real dynamic, the real question is, what is the impact on beneficiary health, whether it's an individual's or a broad population health, if there is no effort whatsoever to constrain or contain costs or to limit kind of financial exposure in the healthcare space? And I would argue that the danger there is perhaps even greater, because a runaway freight train of Medicaid expenditures, is going to lead to big problems. And you can sort of say, hey, I don't like this, it looks like rationing, but you know what? The reality of the world, the reality of state government, the reality of Medicaid is decisions matter, and that some kind of cost constraint, and you can call it rationing if you want, it's either going to be explicit and done thoughtfully, or it's going to be implicit, and maybe done not very thoughtfully. So we've got to figure out how to do this in a way that makes sense. So I think that's, I guess the piece that I'll end on, and I look forward to the conversation, is I think the one area that's really driving a lot of attention, a lot of activity in the States, looking at your map, Bobby, is, some of it is around pharmaceutical costs. And I think that's because, not because anyone is looking at pharma or looking at prescription drugs and saying, here's the sole actor that we think is bad and we need to do something about it. Rather, it's that, efforts are being made at the state Medicaid level to drive value, to drive efficiency, to drive improvements in cost and outcomes. And we've got a lot of levers to be able to do that everywhere in the healthcare system, except really with a lot of prescription drugs. And so you see a lot of attention there because we've kind of done it in a lot of other places, and this is the remaining challenge. And so you're seeing states like a California, like a Massachusetts, like a New York, who are really kind of struggling in this area around, and it's not even like, the 85%, 90% of prescription drugs that are, prescribed today. It's really kind of this new 21st century cures world of products that are coming to market that are, for orphan conditions, that are, being expedited to market. And there's never going to be any competition in terms of manufacturers for them. And the prices are just absolutely astronomical. And so what you're, I think, really seeing is efforts. Maybe it's a blunt tool that gets narrowed down with use, or maybe it's a more surgical tool, but it's efforts by states to say, this is an area where we're really exposed, and we're going to need help to try to figure out how to bring some of those costs down to a more reasonable level. And, I know the folks in Massachusetts will like to say this, that, you know, most of the prescription drug market in Medicaid is working. And that as long as you've got competition in the market, we can make competition work. But when there isn't, and there's never going to be competition in any kind of market, that's a problem. And that's where I think a lot of states are saying we kind of need a new covenant here to figure out how to deal with this in this area. And until we get legislation or sweeping regulatory changes at the federal level to help us, you're going to continue to see states push the envelope on the things that they can control, which might look like budget caps. So that's kind of the landscape of the world as I see it, and I look forward to the conversation.
Wonderful. Thanks, Matt. And now, Mike, let's bring some evidence to the table on what seems to work better or not so well.
Thank you, Bobby. So today I want to share with you results from a study that was recently published in Value in Health that examined the potential impacts of budget caps on health. And I think it's important, next slide, to begin with a key question. This is something that Matt raised. Is there actually a concern, a legitimate concern, that budget caps may impact patient health? And the answer is yes and no. Our analysis did find that there is the potential. It's not uniform across conditions, but it does exist, especially in diseases where there's a significant level of change happening. And there are really two types of change that drove this risk. One had to do with increasing changes in the prevalent population in terms of the number of patients. We found that there was a risk when the number was significantly increasing that there could be less dollars available. And then second is when on a patient health basis, health is improving significantly over time, there can be a potential risk there. In our study, we concluded that there were 3 ways that you can mitigate but not eliminate this risk. The first is design the caps at the total cost of care level. 2, compare the annual growth rates against general inflation plus in a population growth adjusted number. And when your target budget annual growth rates are lower than those rates, you probably should put in place appropriate risk mitigation plans. And then third, you need to monitor vulnerable populations. And those you can identify by evaluating those conditions where you're having changes in prevalence and population level health. But before I delve deeper into the study, I think it's important that you understand why budget caps may impact patient health and to really kind of better understand that connection. Next, please. And there are really 3 things at play here. First, I think it's critical to really understand and appreciate that medical care, especially biopharmaceuticals, have played a key role in driving improvements in patient health. For reference, I included a study here that was published by David Cutler and company last year in Health Fairs. And this study found that approximately 50% of the health gains were attributable to medical care, with a lion's share of that coming from biopharmaceuticals. The second fact is that the innovations that led to these improvements, while cost effective, aren't often cost saving. What this means is that, as a result of this, a portion of the annual increases are, a portion of the annual spending increases, health spending increases, are funding the innovation that really drives patient health. Third factor is, one of the goals is to limit the budget caps is to slow the growth in annual increases. And so depending on how these 3 factors interact determines the potential for patient harm. The other thing I would point out is that people like to reference Medicaid program as a base of how this can be done for success. I think it's important to understand that Medicaid doesn't exist in a silo, that there is a lot of cross-subsidization that happens in our system. It's just the nature of highly fragmented system. And so as we take those lessons and apply them more broadly, we need to keep that important context. All right, so to better understand this dynamic in terms of the potential for patient impact, we examine 3 key questions. Next slide. 1, what role does the level of budget cap play? 2, how do annual growth rates impact patient health? And 3, how does the risk of impact to patient health vary across disease, and why is that variation present? So let me take these one by one. So why did we bother to compare the total cost of care cap versus biopharmaceuticals, given what we heard earlier, that there's only been one state to date that really has implemented some type of drug cap? The answer is simple, and we heard this the prior 2 speakers, is there's growing pressure to increase drug prices. And so we wanted to understand how the potential trade-offs would work if this type of approach was implemented. The second thing is we looked at annual growth rate. As I mentioned on the prior slide, the annual increases in spending help to fund the innovation that drives improvements in patient health. And therefore, we really wanted to understand what are the trade-offs between different strategies in terms of how they control spending versus what the potential risk is to patients. And so in this case, we looked at 3 different strategies. The first strategy allowed costs to grow at the general inflation rate. The second strategy allowed costs to grow at general inflation rate, but also allowed for an adjustment for population growth. And 3, we looked at the strategy that had general inflation plus a disease-specific prevalence adjustment. Finally, our hypothesis was that the risk of patient harm will not be uniform across diseases, rather that it would vary across diseases, and we really wanted to understand that. So to do this analysis, we looked at the 8 conditions that are listed on the slide. We chose these conditions because they are in the top causes of population health harm, and therefore we thought they would be of interest. What we did essentially is we modeled projected costs under the various budget cap scenarios discussed and compared that against historical costs and outcomes. These results obviously are intended to be directional as they are hypothetical, and they're really intended to help inform the budget cap design process. So let's take a look at the first question in terms of what role the level of budget cap plays. Next. And so for simplicity, if you look at the report, there's all kinds of metrics and analysis in there. But for today, I just want to highlight 3 metrics. One is the max impact per patient across the diseases in the years studied. So here under the total cost of care, you see the max patient impact is at $0.34. So a dolly represents a loss of health. And the way to interpret a $0.34 is to interpret it as essentially a loss of approximately 1/3 a year of life, perfect health. The second metric was the number of patients that would be impacted under the approach. And the third was the percent of years where there would be a potential impact. So taking a step back and looking at these 3 metrics and the comparison between total cost of care and biopharmaceutical caps, you can see that the drug cap, basically budget cap, scored worse across all 3 metrics. Biopharmaceutical cap caused an additional $0.38 max impact, or slightly more than 1/3 of a year. Approximately 20 more million patients were impacted under the drug cap for the diseases we looked at, and 26% more of the time there was a potential for impact. So why does this occur? Why do you see these differences happening between a sector level cap like a drug cap versus a total cost of care? And the answer is a lot of times when you have improvements in patient health, you see a shift in site of care, often from inpatient care to less intensive settings of care. This makes it difficult for budget caps to manage spending at the sector level. For example, in the paper, we do a deeper dive into ischemic heart disease. And what you find there over time is that drug caps were actually increasing, but the total cost of care was actually declining with time. So in our model, when we applied a drug cap, patients had lost access to medications that were key in preventing hospitalizations, which everybody knows hospitalizations is a major driver of total cost of care. So what's the key takeaway here? Really, the bottom line is at the end of the day, you should be applying caps at really the cost of care level. It provides the flexibility to manage a budget while still allowing you to achieve your objectives. Next, let's look at the trade-offs as it relates to growth strategy. So here I'm presenting the same three metrics for simplicity. I'm comparing two of the scenarios. One is a strategy that allows costs to grow at inflation only. The second allows costs to grow at inflation plus an adjustment for population. And what you see here is when you allow constrained costs to grow at inflation, that it performs worse than providing an adjustment for population changes. We found specifically that constraining it to general inflation yielded a max possible impact of 1.5 years approximately of impact. Again, impacted about 26 more million patients and had an impact potentially 41% more of the time. Although not presented here, and interestingly enough, we didn't really see any meaningful differences between an approach that uses general inflation plus a population adjustment versus an approach that uses general inflation plus an adjustment for disease level prevalence, which obviously would be more technical, more difficult to implement. So why does this matter? I mean, the bottom line is that states often set up the budget cap growth targets using non-healthcare factors such as inflation, productivity, GDP growth, and et cetera. And so the recommendation here is states really should compare those non-healthcare centric targets against this idea of a general inflation plus a population growth adjustment. And when the set rates are lower than that, there probably should be risk mitigation plans put in place. So which populations are at risk and why? Next slide. Before I answer that question, let me quickly orient you to the chart that I have here. The y-axis is the max impact on a per patient dolly basis. The x-axis is the 8 conditions that we studied. What you notice is that 4 of the conditions, ischemic heart disease, breast cancer, cerebral vascular disease, and rheumatoid arthritis, were predicted to have significant impacts. In contrast, diabetes, COPD, asthma, and AFib were predicted to have minimal impact in terms of patient health. We really wanted to understand more closely what was happening here. And when we dug deeper into the data, what you see is that the diseases that the model predicted that there being an impact had 2 things in common. One is you saw significant changes in the prevalence. So think ischemic heart disease, obviously there's been tremendous growth in obesity, which is obviously a predecessor to ischemic heart disease. So that the basic idea is the more patients growing rapidly means there's potentially less funds available on a per patient basis. The second indicator were changes in population health. So when you looked at the changes in health on a per patient basis for ischemic heart disease, you would find, or rheumatoid arthritis, you would find that there were significant improvements in time. This is an indicator that innovation is driving important changes and thus the potential risk. So how can you apply these findings? Well, clearly, quality metrics program should be part of any budget cap program, but it's not practical or pragmatic to monitor everything. And so this could point you in a direction of some conditions where there might be vulnerable populations, specifically looking retrospectively to identify changes where there's significant growth in the population or where there's significant changes in health over time. Next slide. To kind of briefly summarize, so our analysis did find that there is a potential risk for patient health impact under budget caps. And the key thing there, in addition to the design, was really when there are significant changes happening at the disease level, specifically when you have a fast-growing population or you have significant changes on patient health over time. Again, the ways to mitigate those risks, but not eliminate the risk, is to design your caps at the total cost of care level, to compare the annual growth rates that you set against the general inflation plus a general population adjustment, and put in risk mitigation plans when your rates are lower. And then 3, to monitor vulnerable populations, which we said you could identify by evaluating changes in disease level, population, and population health. With that, thank you and turn it back to Bobby.
Wonderful, Mike. Thank you very, very much. And let's now turn to not the aggregate level of thinking about things, but the patient level and how this plays out into what the patient experiences and the outcomes that they may or may not be able to achieve. So Andrew, help us understand this, if you would.
Thank you for having me, Bobby. Again, my name is Andrew Sperling. I'm the Director of Policy Advocacy for the National Alliance on Mental Illness. I first want to plant the concept, and I didn't come up with this idea. My colleague, Mark Booten, formerly the President of the National Health Council, came up with the idea of the myth of the average. What do you mean, when we talk about patients, what do we mean by the myth of the average? Well, and this certainly applies to the concepts of global caps, because global caps will be based on an average or a mean. Unfortunately, there's a myth that there's an average person out there. There isn't. We are all individual patients. We all have different family histories of disease. We all have, in many cases, multiple chronic conditions, some of which are poorly managed, some of which are well managed. So the idea that we would base any type of calculation or a cap on the average person is going to disadvantage people who have higher costs associated with their care. I also want to borrow from Matt what he taught me years ago, is the 80-20 rule in Medicaid, and that is that 80% of the population, largely women and children, drive 20% of the cost. By contrast, 20% of the Medicaid population, elderly and people with disabilities, drive 80% of the cost. So I represent a population that is in that 20% of beneficiaries that drive 80% of the cost. And their cost is just not there for the behavioral health care. Many people, particularly in the Medicaid program, someone that has a diagnosis of depression or schizophrenia or bipolar disorder, they are highly likely to have not one, not two, but sometimes 3 comorbid chronic medical conditions that drive high costs. So a cap that's based on the average person is by its very nature going to disadvantage someone who has 3 or 4 multiple chronic medical conditions and very high costs associated with their care. From the patient perspective, we want to look at the total cost of care. If you're going to go down the road of budget caps, make sure that you don't just focus on prescription drug costs, but you focus on the total cost of care, recognizing that prescription drug costs are just about 20% of total healthcare costs in our country. We can't afford that 80%. And if you're going to go to if you're going to go down the road of budget caps, we want to make absolutely certain that incentives are aligned in the right way. What do I mean by that? Well, let's focus back on that individual with 3 or 4 multiple chronic medical conditions and underlying depression. We know that those 3 or 4 conditions are likely to be, and that results in them utilizing high cost services like acute inpatient care and other types of long-term care and support services. We want to align incentives so that you can help that individual better manage those comorbid chronic medical conditions. And many of Matt's members are doing very innovative things out there, like focusing on social determinants of health, looking at that at unstable housing, looking at diet, looking at use of tobacco and alcohol and other drugs and other illicit drugs, opioids, to make sure that you are better offering those individuals intensive supports and services. They can better manage those chronic medical conditions and not end up in the emergency room where the costs are driven even higher. So patients and patient organizations are very concerned about the use of caps, particularly their potential to disadvantage people who have higher costs associated with their care. And then most importantly, if you're going to go down this road of having these global caps, make absolutely certain that you align incentives to provide the level of care that people need to better manage particularly chronic medical conditions, to avoid high costs and actually integrate care in ways that actually drive better outcomes. So thank you for having me, Bobby.
Well, thank you all. I think we're now going to go to the Q&A period with all of everybody's smiling faces on the screen so everybody can see them. We, again, welcome your questions, and we are starting to get some of them in. Let me take one of the questions that came from the field first, which is the issue of innovation and its relationship to budget constraints. The questioner said that in New York, parts of New York, they had a budget cap on hospitals, and there was lots of innovation during that time period. We hear from a variety of other sources from the pharmaceutical industry where they say, well, if you constrain revenue and profits, then you're going to reduce innovation. So when might you see that constraints will cause problems, and when might you not? I'll give my simplistic answer, and then I want to hear from you guys. If what you're doing by constraining costs doesn't require capital investment, some of these hospital patients we can handle in the outpatient setting, then you consciously say, I could save money. Let's take care of them as an outpatient. But if you're saying to the hospital, well, yeah, you need to build a new building for this innovation, like a whole nother clinic, that constraint might limit how much they can invest. And certainly on the pharmaceutical side, that's the case. So are constraints going to lead to good things or bad things? And what might be the drivers of that differential outcome? Hemi, do you have any thoughts here?
Yeah, so I might just point to one example. First of all, just to harkening back to sort of Matt's point, Medicaid programs operate on these types of budgets, and they have for many years. And we all know that Medicaid programs continue to innovate. But to talk about just one state as an example, Oregon had to impose, and it's a cap on the growth rate. So I think we need to just maybe parse out a little bit of this. It's not like a blanket mistake. It's like, these cost growth benchmarks that I was talking about is like, let's try to control our spend. And, in Oregon, they were going to have to cut, provider payments. They were going to have to make all sorts of other budget cuts across their system. So they had to find a way to really control that. And coming out of that with their sort of, control of their Medicaid cost growth rate, they also were innovating at the same time. They were building out a whole different way of providing care through coordinated care organizations and, thinking about different ways to address social determinants. And I think we all know in our healthcare system, there is room to drive more value and, really build on different incentives to lower the cost of care and really, improve outcomes. So I guess my view to that question is, yes, I think there's a lot of opportunity to think about, these cost growth benchmarks or other ways to try to control value and innovate at the same time. I mean, I think everyone is trying to create innovation within making sure we have a sustainable path. So
others on this topic?
Yeah, I just reinforce that. I mean, I think the story of Medicaid over the past 50 years is resource constraints are driving the innovation. And if money didn't matter, if it was just like monopoly money and, hey, we're going to spend whatever it is anytime anybody does anything, then Medicaid programs would probably look like they did in like the early 80s, where it was just purely fee for service and Medicaid agency staff, they were just claims processors. You got a claim, okay, we'll pay it. Got a claim, okay, we'll pay it. And that's a reflection of costs weren't big, costs didn't matter. You don't need efficiency, you don't need innovation. But that's not the real world. That hasn't been the real world for decades. Medicaid is driven, again, by this trying to, squeeze between this, this tight opening of you've got to be efficient, you've got to be effective, you've got to be folks. And I really like Andrew's, focus on whole patient care and figuring out how are you getting all of the various pieces, all of the various silos within the health and increasingly the non-health care system to bring to bear around an individual. But again, this is, scarcity drives this. And quite frankly, every single provider type in the entire healthcare industry is going to come out and say, hey, we're different, and here's why you shouldn't do such and such to us. If you do X, then this is going to be bad and patients are going to suffer. Literally every single provider group, I don't believe it. We can do better. To Hamy's point, there's lots of room for efficiency. And I think the other piece is, that's my broad take on the reality of efficiency and innovation. I think though that there is room in this conversation for us to talk about another real world issue, which is that I think to Hamy's point around federal spending, whether it's a 1.9 trillion here and 1.8 trillion there, whatever. What I'm saying is state governments, state budgets do not have the infrastructure to be able to sustain the trajectory that Medicaid is on. And that's true in a lot of places, including long-term services and supports, but increasingly in this space of new and innovative pharmaceutical developments. And what I would say to you and to folks listening on this webinar is, I'm not here to begrudge any manufacturer of the profit margin that they want to make for innovating products in this space. What I am telling you is we can't afford it. And so if you want to continue on this path, you've got to figure out how to get the federal government at the table to shoulder a much bigger burden of the costs.
Okay, thank you. This is really good. Let's pivot a little bit to Mike provided some guidance on how this could be done well. And Hamy reiterated that, which is, you got to adjust. It's not a cap that's nominal. It has to be adjusted for inflation or some type of inflation and prevalence, et cetera, et cetera. But now, how does a state monitor that they're not making a mess out of patient care? So, Andrew, what might a state do from a program evaluation standpoint to make sure we're not making things worse? Penny wise, pound foolish. And clearly, Hamy has a thought here too.
I had to say something before Michael responded. I meant to mention this earlier. There's also quality benchmarks as part of this cost growth benchmark. So I just wanted to be clear. It's not just about setting targets on spend. It's also setting targets on quality. So that's exactly how you do it, right? But anyway, Michael, turning to you.
No, is it turning to Andrew? Andrew, do you have a sense?
Oh, Andrew,
Yes, holding providers and the system accountable for the total outcome of care, right? And looking at social determinants of health, targeting high utilizers of services to actually figure out what is really going on here. Why did this individual have 3 trips to the emergency room last month? And addressing those underlying factors to not only to contain costs, but to get better outcomes, because that's what actually really matters to patients. Am I getting better?
That's great. Mike, did you want to add to this?
Yeah, I was going to chime into that. I think I agree with everybody that the quality metrics are incredibly important. I think my caution is you can't just look at it at an aggregate level across conditions. I think in order to really understand what's going on, you need to start looking at disease level or patient level outcomes to really kind of monitor, because like I said during my brief talk, some conditions are likely to be more vulnerable than others. And if you're looking at an aggregate level, that sometimes can get masked across conditions if you have other conditions improving.
Well, we have time for 1 minute for each person. And so my question for a minute's answer is, are we going to see a lot more of this across the states? And 2, is there any guidance that you would like to synthesize to say, make sure you do it this way? And let's go in the order that we began. So Hamy, then Matt.
Oh, I'm lucky. I get to
Mike,
go first. Okay. Yeah. So I think, just to take a step back, states are going to continue to try to drive more value into the system. They have to balance their budgets. Healthcare costs are a big part of that and continue to rise. And, consumers are asking, can you also lower the cost of healthcare? And that's on the commercial side too, right? Because the premiums are going up and employers are as well. So I think as a collective across payers, there's going to be a continued push to how do we drive, more value into the system, including with the pharmaceutical cost piece of this. So yes, I do think there's going to be more thinking around innovation. I think there'll be a couple more states that are going to look at cost growth benchmarks. I think you're going to see states getting a lot of money, states, localities, et cetera, getting a lot of money in different parts of infrastructure. And, I hope, we can be a part of supporting them and thinking about how to make those investments so we can drive more value into the system. So yeah, that's my take. I look forward to, as we come out of, COVID-19 and recovery, addressing some of what Andrew said is how can the payment and delivery system help drive, whole person care and really helping folks across different pieces of what they need to really just be healthier in the long run. So,
Great.
thanks.
Matt, you now have less than a minute.
Okay, well then I'm just going to ditto everything Hammy said, and then but to reinforce that, like every Medicaid program across the country is focused on this, and whether you're Arizona, that's 100% managed care, or whether you're Connecticut, that's 0% managed care, everything you're doing is figuring out how do you improve the whole patient system of care, and it's not being done at some sort of like, well, on average they're all doing okay, so we're good. It is at the patient level. And of course, we have to acknowledge that some people are going to be more complex, more expensive than others. But that doesn't mean that you can't ignore the costs because, to Andrew's point, 20% of the people may drive 80% of the costs, but you still have to worry about what happens to the other 80% of people.
Very true.
40% of the kids in the country, the 50% of births, everything else.
Yep. Okay, we're going to shift to Mike and then Andrew.
Yeah, so I think in general, yes, there's going to be more use of budget caps. I do think there's a fundamental difference in innovation that requires capital and innovation that doesn't. And I think how we approach each has to be different. That I'm not saying not to do it. I think there's definitely a need to do that. I think in terms of how we do this well is you really need to start focusing on building a continuous learning system where we're constantly iterating and doing better and improving.
So Andrew, you're going to have the final word. Just want to thank everyone, the panelists included, all of you who have attended. There will be an evaluation going out, so by all means, please answer it. And this will be recorded or has been recorded for future viewing so others can log into the NPC Now website and go from there. Andrew, you got the final word.
Focus on integrating care, the whole health of the person, and quality of care.
Fabulous. Well, we made it in the nick of time. You guys were wonderful as panelists. I'm sorry we couldn't get to all of your viewers' questions. We're happy to chat offline and continue this dialogue in a really important topic. Thanks, everyone. Have a great rest of your day.